It is my pleasure to introduce our speaker this morning, our first speaker, President of WAGS, Dr. Stephen Earle, talking about ultrasound-guided gluteal fat transfer.
Thank you, Martin, very, very much. And really thank everybody for being here. It's been really a great conference. Dr. Patino, thank you for everything, and your wife, Brooke, for organization. I mean, I think this year has been truly, truly excellent, and it just gets better every single year. So I'm really excited to be here today. Let's go ahead and get started. So this morning is really all about BBL safety, so I will get into a little bit of the history. I know we all know it, but just to kind of recap kind of what got us here in the first place, okay? And green. I have no disclosures. I don't get paid by anyone. I'm honored to be the president here at WAGS, and it's been a great honor. I hope to continue that. So as we know, before 2017, that's when how valid this number is. But it was widely reported at that time that it was approximately the mortality rate was 1 in 3,000. And so that BBLs in September of 2019. Nearly 2,000 ultrasound-guided BBLs in my career, which is the most of any surgeon here in the US, okay? So let's show you a little bit of what this looks like. So right now, you can see here, up top is gonna be the skin. One here, you see that one? I'm moving it up and down, up and down. That's my cannula, it's in that subcutaneous space. And now I'm going to inject the fat. You're going to see a cloud of fat right there, all along that subcutaneous space. It's in the same area, not going into the muscle. Started the WAGS ultrasound guided gluteal fat transfer course after the meeting last year, I believe. And we've done, I don't know, probably about 6 or 8 courses so far. We've trained close to 30 people. It's been really, we've gotten really, really great feedback for the course, and of course we continue to do so. If anyone, after today has interest in the course, please let us know so that we can start organizing the next one. Okay. And then just a little video about the course. So it is a live demonstration in the operating room. That portion as well, you get your certificate. Anything down. So a lot of people in the room have been to the course. Like I said, I think that we've got to react the same way. It kind of has this pump action, just trying to kind of really actually pump things towards those vessels up to the lungs, and so that's why this is a muscle where we cannot be injecting into or deep to that muscle. There's just no way of doing that safely. And like I said, it certainly doesn't have to affect the results. It can actually call more standard BBL, just depending on ultrasound-guided BBL. And I'm certain that the mortality rate is going to be extremely low. And I think we just need to gather our numbers and put that together and publish it. I think it'll be incredibly impactful, especially coming from us here at WAGS. That's it. Thank you very much.
Thank you. So we have a 0 mortality from ultrasound-guided gluteal fat transfer, Dr. Earle, over 2,000 cases, 0 death. Thank you, our president.
Dr. Earle's talk really is the perfect prelude to mine, and so this is going to be on safety from the American Board of Cosmetic Surgery members, which is not that many members, so relatively small number. But it's one that's been done over 6 years. I don't have any disclosures to make. Actually, my son's here in the audience. He's probably embarrassed that I'm showing his picture right now. And really the objective of this 2-stage, 6-year prospective study was really just to compare the mortality of what we're doing. A few other things we looked at, like injection site as well, multiple other issues. But really the goal was to find out, well, how many fatty black were. We did discover some other things, but it was broken down really from the range in years 2016 to 18, you can see at the bottom, and 2019 to 20 of total cases. So meaning the total cases went down these last 3 years versus 3 years before. So good news is the majority of people were injecting above muscle. Only 3 of the 85 were reported still injecting into the muscle. And we did send these surveys out and say, look, we're not going to say your name. This is completely confidential, because you know how it is. It's always hard to do studies by email and get a good number and get people to admit a big group with wax. So, but the good news is, effectively, now in the last 3 years, there's been 0 fat emboli from the same group of doctors. Well, but it didn't say absolutely use it. It would be nice if we knew, okay. This is copied and pasted from the website. Actually, I like the girl that you have on the website. Whoever did the web, the girl was great. You know? So it gets your attention, but then the wording is sort of boring a little bit. So I sort of highlighted all that, you know, I highlighted the parts that's important. Stay away from the veins, of course. Concentrate on the position of the tip. Avoid the deep angulation. You know, and then pressure. It talks about pressure and discussing this. So this is on the site right now. I think we could improve it a lot, especially when you start combining all these other studies to improve things that you should do, our members should do, and then hopefully we can do a group study with all of the members. Because the bottom line is, it's a very safe procedure, I think, when it's performed properly. And
that's the last one, I think, isn't it? Can you go back to the first slide? There we go. Anyway, I introduced this yesterday, and I was asked to just kind of go through a couple of these points becoming more and more important, as many people in Florida just found out over the last 6 weeks with the new law. And then, so Dr. Earl, Dr. Patino, and then the leadership at, and Dr. Mann, we were kind of kicking this around last year and said, how can we come up with a way to demonstrate that? And basically, it's kind of like for consumers, for legislators, can I have like a seal of excellence? And WAGs, so this was our response to this, was that well, if we can create a simple pathway where we can train ultrasound-guided BBLs, and then basically, you know, show a pathway and then basically issue a certification seal for it. So the simple way that we talked about that was basically taking the WAGs course, like I did it with Dr. Earl, she's on Saturday. It's just again, it's people saying, well, it's just a standard ultrasound, what's the big deal? Well, it's a little more to it than that. There's, you know, there's a little bit of a learning curve, and you want to standardize for safety reasons to standardize your training. And then we wanted to have a simple putting ultrasound, you know, where the cannula is on the screen, and then you can get your seal, and then you can use that, you know, basically in your marketing. So this is so Dr. Business Motor Caesar said, well, why don't you put a QR code on the didactic portion of that? So I did that. So that way people can take a picture if they want to do that, and I'll show that again during my talk. So that'll get you right in, it's all online. So I kept it to $300. If you wanted CME, it was going to be $500, so everybody voted to say, okay, keep it at $300. So anyway, and then Dr. Earl's talked a lot about that, and the nice thing and they've gone out of their way. I mean, Dr. Earl comes in on Saturdays, gets his OR crew there, and you don't have to miss a day of OR. It was a really good experience, and I've sent some friends that actually work from WAGs, and real good experience. And then I was asked, that's 2 or 3 people asked me, well, where could I go for this? Certainly, I think if you really want to do this, I think, Dr. Earl, teaching other surgeons using this standardized ultrasound guiding, ultrasound gluteal fat transfer technique. Anyway, thank you so much for giving me the time to do that. I'll drill down a little bit on some of those numbers later in my talk. Thank you. Thank you.
So if you're not cleaning the instrument, that's another area. So I think all of those help.
And just one more thing to add is I change my fat grafting cannulas every 6 months. So I think that also helps, because even though we do the tickle sterilization and everything else, get the little brush in there and the whole thing, I just feel that there's always some sort of residual that might be in there. So I do change all my fat grafting cannulas every 6 months.
Thank you.
So we send people for cleanings and dental evaluations. What's your thoughts on that?
We don't do anything specifically like that, but we do say, you know, you can't have any like major dental work within 6 weeks of surgery, 6 weeks before to 6 weeks after. That's pretty much all we do.
I'm a little more
Dr. Umberto Palladino, our Vice
I
President.
don't worry about infection, so easily. I do, but we don't use antibiotics in the fat. We give only perioperative antibiotics, and we don't give any antibiotics after the patients. We also don't have the patients wash with heavy cleanse after surgery, especially not for a full week, because I worry about killing the good bacteria on the skin. So we do have them wash the next day with just regular soap, but we do provide them heavy cleanse to shower the night before, and we do clean the body with heavy cleanse, and we put a heavy clean just towel or lap on to cover the anal opening. And I like heavy clean because it's really just covers more than betadine in general. So that's how we do it, and we don't have a very significant. In fact, our infection rate is extremely low, especially for BBLs. And I think
We actually have a special kind of hospital-grade filter in the office that's supposed to like filter out mycobacterium, which we change once a month as well.
Just wanted to know your dosing on the calf flax, your post-surgical.
We to place the fat back into the buttocks. And this may be a little costly, but I use a disposable single-use cannula for the grafting part of it every time.
But it works. If you think about colon and kind of some of the forefathers of fat grafting, they'll tell you that's quite the wrong thing to do. So let's say you have to like put little aliquots with multiple different planes, et cetera, so they can get the blood supply and everything else. But like I said before, the buttock just doesn't work like any other spot, both for the fat embolus issue and for the fat survival issue. So the way that I do it and the way that some of them are talking about now, which I think we call it SIMI, but I don't remember exactly what it stands for. But it's basically you are creating a bolus into that deeper subcutaneous space. You can create, say, a few of them, and then after that, if you want, you can then use your cannula to kind of spread things out. But spread that fat into that deeper subcutaneous space throughout the buttock. So I think that's kind of my thought process on it. We definitely demonstrate this during the course. But part of what we're trying to do with the course is not only to increase the safety for the patient, but we want to make sure that everyone's efficient and continues to be able to do the same number of cases they've been doing before. So that is really taken into consideration. So typically the first thing that I do when I do the course, I kind of draw out what we call the danger zone, which is, you go from the posterior superior iliac spine to the ischial tuberosity. You kind of draw a line through there. That's where you suspect the vessels to be, and then I give myself a little buffer zone beyond that, so typically about 12 centimeters from the midline, of course depending on the patient how big they are. And then that's what we call the danger zone, and that's where you're using the ultrasound. Okay, so you're only using it for that portion of the procedure, so you're putting in, I do injection technique, a little old school in that way, but I only put in maybe between 4 to 6 injections in that area. And then I'm moving on lateral to that, and I put the ultrasound away and just do it, the way we typically do, especially, lateral to that. And demonstrate that, we do, the way the Clarius works, you do basically 30-second clips. So that's why it works well with the injection as well, because I do one injection is about a 30-second clip. So I do it kind of more similar to this side here. So a line from the posterior superior iliac spine. So if you see which is the. Yeah.
Very good.
Okay. Perfect. So there, the posterior superior iliac spine. So if you see the dimples of Venus, as they call it, sometimes it's going to be kind of in that area. You can feel, you can palpate it. And then you go from there down to the ischial tuberosity, and you kind of draw a line that goes straight up and down. And that's approximately kind of the line where the vessels are supposed to be. The superior vessel is going to be approximately, about 8 centimeters from the posterior superior spine, and approximately 6 to 8 centimeters from the midline. And then the inferior gluteal vessels are going to be about, anywhere from 4 to 6 centimeters below that. But I just call this entire area the danger zone, and then I'd like to give myself a little
walking microphone. It's a pleasure to be here. Thank you very much to Dr. Patino and his wonderful family to really, helping organize this event. It's also a pleasure to be with this group of really entrepreneurial and bright surgeons that, it's more and more, I enjoy way more these type of meetings than the big meetings. So it's always the same and the same and the same way. Today, what we're going to try to do, I try to condense my talk, so it's going to go a little bit fast. Because I really want to present what we are doing for patient care. I'm going to give you a little bit of a hint of the future here in our presentation. And it's good to have with me Natasha Turner and Steve Bell, and tell you a little bit more about them. So I moved to Florida 5 years ago after practicing traditional plastic surgery in Texas. And I say traditional plastic surgery because that's where we.
So a little bit about Med Miami. We provide both surgeons and clients with a license option for post-op care after surgery. And when I say both,
I want to take a moment to honor our Vice President. Stand up. Humberto Paladino. We could not be more pleased to have one. And our President, Dr. Alexander Earl, these 2 stars is incredible. This is an incredible presentation. I have over 1 million questions, and I'm sure you do also, but we're gonna do it afterwards. So we're gonna move everything down. We're gonna have plenty of time, but we're gonna just move everything down. Let's go to lunch. We'll come back and we'll do questions and answers. And we're gonna have a good half an hour of question and answers, and then we move everything back. Sounds good? Excellent. Thank you. Wow, nice meal here. Sitting down for a meal with Dr. Ladipo and Dr. Gordon Anden. Very good. And our president, Dr. Stephen Alexander R. Dr. George Solomon. It's an incredible buffet here. And we have a beautiful view of the, look at that view. We have an ocean view. Hey, my friend, my dear friend, how are you? Dr. Gregory Aloof, this man I love. Oh, thank you. Very good. Look at the view here, you guys. It's incredible. It's gorgeous. Oh, look at that. Hi. Good.
Just a real quick question for our attorney friend, great presentation. Talking about going bare, is binding arbitration used a lot here in Florida?
Binding arbitration in Florida is very tricky because she asked, put a little more detail into it, not make it so routine and so robotic. Part of it was your topic there, but the more detail you put into it, that it was a real conversation, because we heard this already, every patient that you mentioned.
We have a computer system that has voice recognition. So let's say the patient is sitting in front of me and I'm talking to the patient. We have chest pain, shortness of breath, nausea, vomit, diarrhea, constipation. The whole thing is being recorded immediately. And then in addition to that, I have a 25 checkpoint list of a consultation that covers everything. And so far, it's worked for me. I don't know how that would. And if anybody wants a copy of the 25-point consultation checklist, I'll be happy to give it to them. And it's the time you spend with the patient is all documented. By the time I'm done with the consultation, it includes everything.
Just a comment about voice. Be as nice as Sandra was yesterday with the introductions, but here we have Dr. Mercado. I mean, he is an amazing entrepreneur, innovator. We saw him in multiple talks and things, and it's a pleasure really to have him as part of these groups. I'm looking forward to visiting him in Colombia and seeing firsthand what he does, and we are going to enjoy one more of his amazing talks. Thank you very much.
Okay, thank you everybody. The topic today actually has to do with this question that probably all of us have encountered in our office. It has to do with a patient that show
who is such a valuable asset to this organization. I think, I know in his recent plans is to retire, and he can retire all he wants from practicing, but he cannot retire from wax. And he is mandated by all the board members in wax to stay with us and help us out with his energy and his wisdom, because of his experience is really pretty amazing. And thank you for being here and having you.
We can also train you in ultrasound, the fat grafting technique here in Miami to do that. So let me just what I'm going to do, I'm going to run through some of those numbers that you saw, and I want to show you a different perspective. My talk is a little different in that I'm going to call out a couple of controversial things, and I hope there's, he talked about the arrows, right? It's not the arrows, it's the Indians, and I think you're going to see that, right? A little bit about that. And then Rod Rourke wrote a patient safety article, this is a couple years ago, I believe. And if you look at the 1 in 20,000 and what's 13 versus 1 in 13,000, the BBL is actually safer than abdominoplasty. So we thought, that's kind of cool, right? And then, BBL problem had been solved, right? Subcutaneous, 4 millimeter, or blunt cannula, and inject parallel. It's such a game changer for the BBL safety thing that something always happens afterwards. And now, we'll talk about 1471. But you had to use ultrasound guidance, and it limited at least initially 3 BBLs a day. And then now I want to show you this. That was only a 90-day rule, and then it was kind of like you didn't have to have the results. So the question was, why traditional training models? Because that's how we got here. You have people that wasn't necessarily trained in BBLs, that they come out, nobody's really paying for free flaps or fixing dog bites in the ER, which I know all that all too well. It's all self-paid, and my kid was supposed to be a model, now it's chewed up and you get sued. Well, you gotta go do BBLs. I can see if you're trained out doing that, but the traditional model is not training them well. So organization can, like WAGs, can really take the leadership into doing that. So that's why I'm really excited with what Humberto's talking about, with basically really promoting, safety and his efforts in doing that with Alexander Earl and also and Gabriel. That's why I'm here, basically helping out this organization, because you want to be a fighter pilot, but you want to be a fighter pilot flying the right mission. Does that make sense, guys?
Yes.
So anyway, and then here's the thing to talk about, so Stephen shared with me, his young associate, very well trained, watched 2 or 3 BBLs, and Dr. Earl's kind of like, I'm like, I've been doing BBL 15 years. This is a hassle. I don't want to do it. I think it's a waste of time. I was wrong, guys. I'll totally come 180 on this whole year. And I was kind of sharing my experience with you. The thing is like, this is going to take time, it's going to cost me more money, I already know how to do it. But it's not really all about you anymore. If each one of you guys, WAGS has the best, basically, like I said, the best numbers. But you need to basically promote to a better standard so everybody can come on board with that. And that's where it's being driven to, because you're being held accountable to all those other mistakes out there. Because when I lectured at ACS this last time in Florida, in San Diego, they were like, that's a Florida problem, why are we getting to do it? That's because it affects the rest of us around the nation. So adopting a standardized training program, that's how they do it in the airlines, that's how they do it in the military, in industry-wide, in the system. And then it's 1 in 17,000, and then there was another point Angelo said was, what he said was 1 in 14,000 is what his, so that's what the ABCS stuff is doing. So 1 in 23,000. So again, it's just an opportunity, and I won't spend much time on this, I've bored you guys with this enough. So the 2 things is, so El Presidente, Dr. Earl, said that I could even, as other people said, well, he add the word certified into the WAGS certification, so he approved. So the WAGS, he wanted to add ultrasound guided BBL. So I think that's the deal. And then, like I said, take the course. It is a little, I get it, it's a little steep, but they're giving up the entirety for you. And if you want to do other days, you can go with Humberto, you can go with Carlos, and then Patino, and then also, Dr. Earl. So I would really encourage you to do that so they can set it up for you. Like I said, you've had, I did it. I paid my $5,000 just like everyone else. So and then if you decide you really want to do this deal, then then do the 300.
Yeah, okay. I'll be here because I'm a little short. Hi. So yesterday or 2 days ago, when Julian was at our office, he shared an experience saying that he was one time with Dr. Pitani, then he asked him, how many complications have you had? And he said, all of them, right? So we all have complications, and of course, if we do surgery, we're going to get complications. And of course, in order to have a BBL, we have to do liposuction. These are my financial obligations that I discussed. So this is the statistics in 2021. Now liposuction passed breast augmentation. We used to say breast augmentation is the most common procedure in the world. Now liposuction is the most common procedure in the world, and also in the United States. These are the complications, right? We know contour irregularity.
Start with some questions. Anybody has questions? Maybe this over time. Will be huge.
But that don't takes away the importance and being also well. So when you're talking about a
Mortality of the BBL.
Is mostly of color, and they use a lot of the skin bleaching creams.
Hydroquinone skin cream?
Well, it was a cream she got from CHINA, and it had a lot of stuff in it.
My English is not very good, so Dr. Patino helped me with the presentation. Okay, my pleasure. Sí, para adelante, el otro del rodito para atrás y tienes el láser ahí también. Okay. Vamos a hacer un pequeño recorderis de cómo nació la liposucción. Let's review how liposuction was born. En los años 20, un cirujano francés, 1920s, a French surgeon, realiza la primera succión grasa, makes the first liposuction, por medio de curetas ginecológicas, through gynecological curettes. 50s, un cirujano alemán, a German surgeon, practica nuevamente la extracción de la grasa por medio de curetas, using curettes, a un bailarín, to a dancer, con resultados también desastrosos. With disastrous. Ya hacia el año 65, toward 1965, los doctores Fisher, Dr. Fisher, padre e hijo, desarrollan la cánula que actualmente utilizamos. Develops the current cannula that we use today. Remember a bit the muscular fibers. El pectoral mayor. The pectoralis major and the pectoralis minor. Donde el pectoral mayor tiene una definición, un origen, has an origin, vertical, y el pectoral inferior, pectoralis menor, tiene unas fibras transversales. Transverse fibers. En la gran mayoría de hombres que tienen ginecomastia, males that have gynecomastia, en una definición muscular vamos a retirar. When we're doing muscle definition, we are going to remove el borde inferior, the inferior border, y proyectar and also project the superior border. Eso va a dar una proyección más atlética. This is going to give a more athletic appearance. Quienes hemos podido hacer el curso de alta definición, the ones that have been able to do the high definition liposuction course, una cánula de aproximadamente 5, approximately 5 millimeter in diameter, about 4 or 5 millimeters, and in a superficial plane with a cannula with a lesser diameter. Inicialmente realizamos la lipoaspiración, the lipoaspiration en los planos profundos, in the deep planes, que nos van a limitar los límites grasos que vamos a dejar. Avoid leaving too much fat. Ustedes sostienen con el pinch test. With your hands, you do the pinch test. Y saben, and ya con su mano with your hand, with your educated surgical hands, ¿qué panículos están dejando? What kind of panniculus are you leaving in the superficial plane? Aquí ya modifiqué la técnica. I changed the technique already. Y las incisiones son 3 suprapúbicas. Are 3 in the suprapubic area. Una periombiliar. 1 semillunaris. Transversos oblique. Transverse and oblique muscles. Retiramos la parte inferior. Remove the inferior aspect pectoral of the pectoralis. Y lipoinyectamos en la parte superior. We did a fat transfer to the upper pole. Un caso de una paciente en postoperatorio inmediato. This is a postoperative immediate result. Otro paciente, another patient, 3 meses, 3 months in the postoperative period. Si ustedes se dan cuenta, no
If you can
tenemos
tell,
irregularidades.
we do not have any irregularities.
Lo más común las son las hiperpigmentaciones
The
posinflamatorias.
most common things are hyperpigmentary lesions.
Y siempre
And
tratan de
always
disimular las incisiones.
we try to hide those incisions.
Tenía un paciente en vista lateral.
It's a lateral view on this patient.
Este paciente
This patient
está indicado para una tummy tuck.
needs a tummy.
Eternally grateful to him for this amazing gathering and putting together along with Dr. Miami, this wonderful group of people. And also want to have Michael Rodriguez also talk about bloodless ultrasound and gluteal fat transfer. So, Dr. Patino.
Thank you, Mr. Vice President. I'm so proud to be here and be next to you. Humberto has a wealth of experience, and so does Dr. Earl. Thank you all very much. Thank you all for being here. This has been an incredible meeting, and I'm very pleased. I'm just gonna go out, and the first thing that you see here is how is that even possible to do bloodless? It's impossible. So I'm gonna show you, it's probably impossible if you do liposuction the way that most people do it. But I do it a little different. And I turn the patient lateral all the time. I love this position. The South Americans do it this way as well. But don't go on the lateral this way, because when the patient is lateral, the viscera come forward, and most of the problems are there. So if you put the patient lateral, work on your back. Don't go back. And the best thing about lidocaine, all of these, forget about the postoperative pain and all the things. The best thing is that, and I don't give my patients prophylaxis for other than early ambulation, and we are exaggerated as far as the stockings that go all the way up here, and also the compression boots go all the way up. Why? Because 80% of the blood clots come from above the knee. I go and I see many operating rooms, they have below the knee. All 80% of the blood clots come from above the knee. So I go all above the knee and I just walk them. But you can tell the patient, hey, walk all the way. I want you to walk 1 mile the first day, 2 miles the second day, 3 miles the third day. Here.
Hi, Dr. Patino here at the Cosmetic Surgery Los Cerritos. So what we're doing is tumescent anesthesia. The patient is very, very well tumesced. We did the front and the back. We're going to do micro-air, power-assisted liposuction to the inframammary, upper abdomen, lower abdomen, the mid-back, flanks, hips, the lower back, and we're going to do ultrasound gluteal fat transfer today. This remains yellow and beautiful, and what's going to go into her buttocks is going to be yellow, beautiful fat, okay? And that will improve also the survival of the fat graft. Why? Because what we're putting is basically 100% fat. There is no blood in there, right? Look at it, and you're gonna please pay attention to when we put the fat graft into the buttocks under ultrasound, and you want to and the deep links, right? And then probably after that, the most important thing is to wait a good hour. So you tumesce slowly, don't tumesce in 5 minutes and then start this. It is going to be bleeding for sure. So you tumesce, you wait a good hour, and then you start, right? 0.5 centimeters. You can go all the way back here. Can you see from back there? All the way to the mid back here. Can you see it? Yeah. Yeah. So very, very uniform. Everywhere you go is at 0.5 centimeters. So she looks good. She's got a nice waist. And we're going to turn her to on the other side. So notice the complete absence of blood in the fat graft. It's incredible. And that's because we collected it this way. You saw it, right? And so I think this is important. It's very important for fat retention. And we're going to show you the ultrasound as we're doing it right now.
Alright, so we're doing ultrasound guided gluteal fat transfer. This is Dr. Patino's cannula right here.
Also tells me this is a danger area. So it's a simple thing. I don't even need to mark the area. And now we're going to proceed and safely do these under ultrasound guidance. And we have 15 centers in the United States where we teach doctors how to do this safely under ultrasound at the World Association of Urologic Surgeons. Thank you.
Okay, and I use my credit card system on my cases. I don't have any financial disclosures. Wow, thank you for this invitation, you guys. This is incredible. Look at this food, man. Wow. It's a great time here. All the surgeons, or some of us that got invited. And look at this, huh? And wow, it's incredible food here. Wow, this is incredible. The amount of food here is incredible. Sí, también. Wow. Man. Well, thank you for the invitation, you guys. Incredible. The most famous surgeons in the world. Wow, you guys, these are just appetizers for us. We, on top of these, we're ordering a separate meal. That's incredible. Dr. Latito, a lot of doctors here. Hey, you guys, is this better than working or no? A little bit better than working. Hey, is this better than working or no?
Way much better.
Way much better than working,
This is
huh?
one of the stages of life.
You sure?
Enjoy it with friends and family.
You sure? What about you guys?
Oh, perfect.
Perfect. Better than working?
Oh, better.
Awesome. Beautiful. Wow, look at this. More food after all of that. Incredible, my lord. This is incredible. Wow.
Overdoing it.
Incredible. Wow. Bon appetit!
I feel guilty for many reasons. My waistline is one of them.
Happy birthday, Dr. Paredes! Wow. Pathologist from Colombia. It's his birthday today. No, it's for him, of course. I already had my day. Look at that. Hey. Happy birthday, Dr. Paredes.